Good afternoon, everyone. Sorry we are a few minutes late. We're just having a few technical difficulties. But thank you all for joining us this afternoon for our CAQH Core and X12 webinar series. In this series, we are actually going to have part 3 of our eligibility and benefit transaction and operating rule webinar series. If you didn't see part 1 and part 2, you can go ahead and take a look at those on our website when you have the time, caqh.org/events, and you can see the first 2 in this installment from 2022. But hopefully you were able to catch those last year or refresh yourselves on the introductory level webinars, and today we're going to do a much deeper dive. Looking at the next slide, I'm going to run through our agenda. First, we'll have an X12 overview, followed by a core overview, just to level set the audience on what our organizations do. And the majority of today's presentation will actually be a panel discussion. And so we'll have a discussion joined by our guest speakers, who I'll allow to introduce themselves in just a minute. But they're going to discuss the CPT SDC crosswalk, copay maximums and accumulators, the multiple 271 responses, COB payer name, and date of service. And there'll be a few questions that our guest speakers help answer as they discuss those various topics. Then we'll open it up to audience questions, and we'll wrap things up with a call to action. Before we go ahead and start the webinar, you can access today's materials right now. If you want to download the slides, you can do so on the right-hand side of your screen by downloading them from that handout section of the GoToWebinar menu. We'll also be sending out an email to all audience members and anyone who had registered in the next 1 to 2 business days. And that will have a link to the recording of today's presentation, as well as where to find a copy of the slides to download later on. Like I said, we should have time for questions at the end. So if you have a question, please feel free to submit it at any time. You don't have to wait till the end to submit it. You can go ahead and do that on your GoToWebinar menu in that questions section on the right-hand side of your screen. All right, so like I mentioned earlier, we are having a bit of a technical difficulty. Bob, are you able to hear me okay?
I can hear you. Can you hear me?
Yes, I can. So right now we have
Great.
Bob and Evert on the phone, and Michelle and Donna are still trying to join. But Bob, I'll pass it over to you just to do some brief introductions.
Great, thank you. Good afternoon. Bob Bowman, I'm the principal of interoperability and standards here at CAQH Core. I've been working on the eligibility operating rules since their inception pretty much for the last 15 years, working really closely with X12 as they develop the standard and we develop the operating rules that support the standard and its implementations. So with that, I'll hand it over to Everett. Everett, would you like to introduce yourself?
Yes, I would. My name is Everett Ford. I work for Optum within the context of Optum. I'm a product manager. I deal with products that basically validate the X12 transaction. And as part of X12, I'm one of the co-chairs along with Donna Campbell for the eligibility and benefits work group.
Great, thank you, Everett. I'm so glad you can join us this afternoon. Donna, have you been able to join? It looks like you're on. Can you?
Yep, I'm
Perfect.
on.
There you are.
I'm
like
Donna Campbell. Oh, did you already introduce me?
I have not. Would you go?
Okay.
You can go.
Okay, my name's Donna Campbell. Everett kind of introduced me a bit. I am a product manager over the provider portal provider connectivity space at Healthcare Service Corporation. And I oversee the 270, 271, 276, 277, 275, and a few other transaction exchanges under my umbrella that are proprietary. And I am here to help answer any questions that are burning for you.
Great, welcome, Donna. And I know Michelle is also having some trouble getting in. Michelle, are you on the call yet?
Hopefully you can hear me.
We can.
Great. So you were doing intros.
Correct.
So Bob, you want me to introduce myself? Okay.
Yes, please.
Great. Good afternoon, everyone. I'm Michelle Berry. I work at Eligibility, but my representation today is around X12 liaison to core. and excited for the opportunity to spend with you and team today. Again, that is my role, so X12 liaison to core, and I will kick it back over to Jackie, Bob, Sarah.
Great, thank you. And actually, Michelle, we'll have you go ahead and kick off with the introduction for X12.
Great. So everyone should be seeing the slides, so I apologize. Unfortunately, technical difficulties, you only have me via voice. So couple of things, eligibility and benefits. Let's talk about that today. Before we do, we're going to get into some X12 kind of disclaimers and discussion about who we are, because previously in our other two sessions that we've had around eligibility and benefits and core operating rules, we went into the specific details. But really, again, X12, we're here to present information. And again, it's for informational purposes. This presentation is intended to represent no legal advice. So again, just want to make sure that everybody is fully aware of that. And the content is at point in time. So it's subject to revisions and changes. If you have any questions regarding specific information, please feel free to reach out at info@x12.org or visit, which we would love for you to do, at www.x12.org. And again, any additional questions that you may have. Next slide around topics. Again, we just are going to be talking really quickly about X12 because we want to get into the meat of the discussion, and that's the great panel discussion we're going to have for you today. And then we're going to talk about resources and reminders. We're going to wrap up. Next slide around background, and if we could connect to the next slide, the organizational structure around X12. I know we've talked about this in detail, but I'm going to recap some really significant information here around X12. Why we're here, what we do, and how we function. We take wholeheartedly into effect our consensus-based technology, our infrastructure on how we cross industries. And again, when I say industries, legitimately, we're talking other industries. It's not just about insurance. Even though we would like to think it is, we also focus on communication, finance, insurance, etc. So again, cross-industry interoperable data interchanges. So if you keep that in mind, those standards that we create have been proven to be very solid, reliable, effective, and efficient in supporting organizations, including retail, for over 40 years. Can you imagine? Over 40 years. And with that in mind, the electronic capabilities of transacting information from one entity to another, that's something that's really stands out above and beyond how we communicate. The next slide, we have billions of transactions. Just imagine billions of transactions every single day, from retail to finance, communication, insurance, that utilizes the X12-based standards to communicate, to exchange data. Also, millions of entities around the world have established this infrastructure to continue that significant transacting of information and representing significant investment in maintaining the stability of that level of communication and infrastructure. Data exchange. Again, as we discussed, it's true and tried, solid bones of keeping communication going across all industries. The next slide talks about X12 products. When we talk about products, we do have a product library. So if you think about work products as we have in our world today, EDI standards are a part of that somehow, some way. So if you really look at how we effectively communicate, those libraries of information or those structures of products and library information is available for reviewing, looking at schemas, making sure from an EDI standard perspective, looking at the implementation guides, and all of that information built around the industry and how the information exchanges work. The next slide, again, finalizing the approaches here, we focus on being very open-minded. We have a vision at the end of the day and the beginning of the day. It's not just about at the end of the day. We're looking at it throughout the day. What can we do differently? How can we communicate more effectively? What other ways can we use emerging technologies and developments? And then in addition to that, think about those business requirements, those use cases, real live productive use cases, and even forward thinking of use cases to bring around collaborating and establishing good open lines of communication. The next slide, talking about just a quick wrap up from an X12 perspective. The resources that we have available for you is if you do have a request for information, otherwise known as an RFI, strongly suggest you submit that information through our online request for information, and that is x12.org resources request for interpretation. Once you submit that information, it will go through our pipeline. And again, we want to make sure you understand this is information that is being responded to, not to be a source or a level of compliance. This is information based on our implementation guides and TR3s, our technical reports. Last resources slide, we talk about maintenance requests or code maintenance requests, otherwise known as MRs. So if you think about how we do our work on a daily basis, if there's a request or a need for change, you can submit an actual MR through x12.org/resources and forms. And that allows you to submit requests to our TR2s, TR3s implementation guides. And again, it allows you to request code changes and again, keeping those specifications going. So we'd love to hear from you. If you have any changes, feel free to reach out. Again, just a quick reminder, X12 has a huge library of resources and materials. Would really appreciate the opportunity for you to go check out our information through Information Center, x12.org, and here's some of those materials that you can check out at our website. Last but not least, I am going to say, stay connected. If you want to know from a social media perspective where we're at, what we're doing, come to our website first and foremost, x12.org. We have our meetings that we post in our site, so you know exactly where we're going to be located and when. Also, if you're interested, social media, we are social media buffs. So come out, enjoy the social media. We would appreciate, Twitter is no longer Twitter, it's X, but you still tweet on X. And then again, from a LinkedIn perspective, come join us, #X12. And any additional feedback, we would love and welcome feedback at x12.org feedback. So Bob, I'm going to go ahead and turn it over to you. Thank you.
Great, great. Thanks you, Michelle. And again, we want to move into the discussion part, so I'll go pretty quick over our overview as well. CORE is mission and driven organization. We do support standards. We ensure that we work with the standards as they exist and look at the business needs that are required as we're conducting business on a day-to-day basis and how quickly that changes. So we're looking to ensure that we accelerate interoperability, align administrative and clinical activities. We work with our constituencies, our providers, our health plans, our consumers, and all of the vendors to help support all of these transactions and interactions. We are an industry-wide facilitator. We are an association, and we bring people together to ensure that we look at what those challenges are in the industry and then help find ways to remediate them and make them a lot easier and smoother for folks. On the next slide, you'll see that we are federally designated by HHS to write operating rules for HIPAA-mandated administrative transactions. we do develop those business rules. We look at, again, where the business challenges are, where the technology is at, where the data is at, and making sure that our multi-stakeholder board members, which are made up of health plans, providers, vendors, government entities, and a number of advisors from the SDO organizations, are all in sync and working lockstep together to make sure that we can develop operating rules that meet business needs. You can see that on the next slide, we have over 100 participating organizations, ranging from government, health plan, vendors, clearinghouses, providers, and many other organizations that help support this entire environment of bringing the industry together to work on operating rules. Our operating rules on the next slide, you can see, run the entire gamut of the revenue cycle. So no matter where you're at, there's probably a standard, there's probably a set of operating rules to help make things a little bit easier and smoother to exchange that data. Again, today our focus is benefits and eligibility, and we can jump right into our discussion topics. So again, the entire panel is here for your questions. I'll go ahead and ask you again, if you have any questions that come up to mind during the discussion, please just pop them into our questions panel on the right-hand side of your deck, probably. We'll try to address those as they come in on that topic. If you have something that's not necessarily on topic, we might hold it to it comes in, so we'll try to address those. We also had some questions come in through the pre-registration process. So lots of folks have submitted questions already. Those are our seed questions that we're going to start the conversation with this afternoon. And we do have a number of topics that we wanted to highlight. I'm going to go ahead and move down to the next slide. And our first topic that came in is the CPT STC crosswalk. Well, what is this, right? And I'll probably have our X12 experts weigh in on this for sure, but the STC is a code set that's part of the transaction itself. And it exists, and people use these codes to get information about a specific benefit that a member may have. But this CPT STC crosswalk, maybe I'll start with Donna. Donna, what do you think they mean by this? Why hasn't the industry come together and developed an industry-wide crosswalk for CPTs and STCs?
Because that is hard, hard.
Exactly.
I think from my perspective in the X12 domain with that hat on, part of the question is there a predefined, A goes to B, one to many, many to one relationship with some of the CPT and for that matter, all of the procedure codes. It doesn't even have to be just limited to CPT. It could be the American Dental codes, it could be the HCPCS codes, it could be the drug codes. And I think what we have found in being asked this question several times over is that there's probably a good exercise that could be done with a CPT or a HCPCS mapping to a service type code list, but it's also very apples to oranges. The service type code list is so high level and so indicative of, say, a policy. What are some of the general categories that are covered from a benefit standpoint on a particular plan or policy for a member? And the CPT and the HCPCS codes are really, how am I going to get paid when I'm a provider conducting the service? And what is that responsibility of that member at the end of that payment cycle, after the claim's been adjudicated, after there's a diagnosis that's been rendered, after there's a few modifiers that can tweak and tailor the response a little differently? So it's almost a little difficult to say that there's an easy way to do a crosswalk, so to speak, between procedure codes and service type codes. But I do think, and in the conversations that we've had with CAQH Core, and even internal to some of our X12 conversations at our work group level, we've talked about whether or not there'd be a benefit to kind of categorize, like, what do we mean by medical care? What CPT codes could be considered medical care? What do we mean by surgery? A lot of different ones could be considered for the service type code 2 surgery. But again, there's a large list of procedure codes, and any one of those procedure codes could be tied back to a CPT, a service type code. So it's really a question of, what is your book of business? What is the policy for the member? What is the provider type? So there's a lot that goes into it that a crosswalk just wouldn't do it justice on its surface.
Right, lots of considerations there. I think you give a good example there for surgery, right? Surgery has, is it orthoscopic surgery? Is it a knee surgery? Is it a surgeon that is doing an office visit for a consultation? How do you understand what that might mean from an eligibility benefit perspective? Like, yes, you can meet with your surgeon and have this consultation versus here you're meeting with your surgery for actual surgery. And those mean two different things, both for your eligibility and benefit, as well as for that claim that comes in after the case for both of those. So there's a big divide in what some of the definitions are, what some of the services might mean, and what the provider is looking for at any given moment about that delivery of care option, right?
Right, and to also mention, you know, the diagnosis plays a major role in sometimes determining whether or not surgery is a covered benefit on a member's policy. And a lot of that has to go back to the idea of just using an easy example, cosmetic surgery. You know, if you have a deviated septum, for example, and you're having a hard time breathing, that's most likely covered under your major medical or your medical insurance because you have a problem with, you know, consistently breathing and having trouble breathing, which is not good for your health and not good for your longevity. However, if you're just doing it because you need some cosmetic appearance change and it's not for a health or medical reason, then you have to deal with medical necessity. And that's where that diagnosis might make a difference between whether it's covered at 100% or 80% or whatever your structure is in the policy and the plan, or whether it's not covered at all and the member has to pay 100% out of pocket.
Right. Makes a big difference in how that, what that might mean for you as a member too, right? So you have to understand your benefits pretty closely, right? And what your diagnosis and what your prognosis and what those modifiers all mean on the back end for the claims adjudication process too, and what that might mean for you kind of like out-of-pocket expense. You mentioned 100%, 80%, 50%, plus co-pays and deductibles play into that too. So maybe another question around STC codes that we have here, and I'll broaden this question to Michelle or Everett as well if you want to jump in. What's the limitation that health plans only accept one STC code, right? Can they accept more than one? Or are they responding to only one? Where do you see the industry at with this STC code kind of submission process?
I like to talk too much, so I'm gonna let Everett talk if he wants to.
I'm happy to talk to this. Just in my experience in dealing with different payers, some payers want to only accept a very general STC code like STC 30, and others have a whole spectrum of STC codes that they have no problem getting specific answers to, and it's really more, in my opinion, aligned with the business structure of how specific payers are set up, rather than, I'd hesitate to say that it's even any broad thing. The industry as a whole does one particular thing. It really seems to me to be very specific to individual payers and how they choose to handle different STC codes. I've seen several payers that'll accept in the range of 8 or 10 STC codes. Some will accept hundreds of STC codes, and it's just you can't pin it down in an easy way. It seems more arbitrary than specific from my perspective.
Yeah, so
oh, go ahead, Bob. Go ahead.
I was just going to add, it might be difficult for providers to know, right? Can I submit 1 or can I submit 10 or can I submit 15? And then what actually comes back? If I submit 1, I get 10 back. If I submit 10, then I get 30 back. The variability is on both ends of that equation.
Many payers have well-defined sets in payer companion guides that they provide or make available on their websites. And I mean, if in some situations that's, you can just go download it, look it up and deal with it. But sometimes in certain situations, like for example, a clearinghouse, you may deal with hundreds and hundreds of payers, and that's not such a ready solution to just say, go look at the payer's companion guide.
Right, and I was gonna mention that, when you look at the actual TR3 itself, there are some, it doesn't say anything specifically about what the max number of service type codes are that must be supported. But there are pieces of the front matter, I believe there's one that basically says that a payer or a clearinghouse should technically be able to handle anything that can be handled in the TR3. So for example, meaning you might not have to process the 270 service type code and answer each service type code question, but if 99 of them come in, you can't hurt your system, you can't kill it. You can't say I'm not accepting this, because in the TR3 itself, it allows for those 99 service type codes to come in the 270. So that means whoever's receiving that 270, even if they only process one of those service type codes and answer the question of that one, they can't reject that transaction because 99 came in, because the guide allows for that. So the number of repeats and the loops and so forth and so on have to be kept in mind, that to be compliant with the implementation guide is different than applying the business of what is supported in the implementation guide to some extent. And then on the flip side, nugget for the future, I know our work group has talked about and put in the future versions a requirement to support a minimum number of service type codes to get to a closer endpoint or future state where a provider who is doing a portal-based inquiry isn't required to resubmit the same information for the member and their MPI and maybe their provider type or specialty through taxonomy. They're not required to resubmit that over and over and over again to get 10 different questions asked and answered. This will helpfully move people forward to being able to support a larger quantity of service type codes on the inbound, and then figuring out where some of the responses overlap and keeping in mind some of the operating rules where there's plan-based and benefit-based deductible, copay, co-insurance, that, really returning the information that is applicable, that is well-rounded and applicable to the plan versus the answers to the questions that are specifically about the benefit. And then also to add on, just because a service type code comes in, one service type code comes in, and I'll use the surgery, for example, again, doesn't mean that the payer or the information source is only allowed to only answer that surgery. They can go beyond that surgery. If they have other things they need to quantify or qualify that surgery with, like surgical assistance or anesthesiology or the hospital room and board or emergency, whatever the case is, if there's other service type codes that you would traditionally return when a surgery service type code comes in, then naturally you can return those additional service type codes to help give a global picture of what's covered in that context.
So maybe as taking a step back, it seems like there's lots of variability, that the implementation guide allows for the provider to request specific data, the health plan to respond to those specific requests. But because that variability, it's hard to judge what really might be available, because perhaps the provider's EHR or practice management software hasn't turned on all the bells and whistles yet, and the health plans may not be able to respond with all the bells and whistles just yet. There's a lot of variability. What kind of guidance can we provide the industry on where's a happy medium, or can we? Everett, you work for a large entity that's in this space. Do you allow for anything in, anything out, whatever comes in, you try to process, perhaps, or how does that sit for you?
So any service type code that is available in the guide is processed, but some of them may just get the same responses, like with some of them may not get the specific response for that service type code. In other words, if the system is not set up to process that specific service type code, you might get a response with the available benefits, rather than getting a specific response to that specific code.
Yep. I know another topic that I know we've addressed in some of our operating rules is the submission of a CPT or HCPCS code in the transaction versus an STC code. That's a functionality that's allowable within the transaction itself, right? Within the 270, 271 transaction, a provider could submit a CPT or HCPCS code. The question is, how available is that in the market today? How many health plans support that level of detail? I would reckon it's probably not that extensive from our understanding, but the latest core update to our eligibility operating rules would allow for physical therapy, occupational therapy, imaging, and surgery-based CPTs and HCPCS to be included on those transactions for return of benefits. Do you guys have any sense of how common it might be for health plans to support this yet? Or do you plan on supporting this in the future? Or where's the debate within the industry right now on this topic?
Well, from
So
my payer perspective, the debate usually has to go with the way the benefits are coded for
Mhm.
the policies and the plans, that they're not coded when we're building them on our system to be exactly the way a claim would get in. So there's a lot of transformation, and kind of like the CPT to service type code crosswalk, there's
Yep.
a similar set of activities that have to happen when it's a procedure code to say how you've coded your system crosswalk. And when you now have double and triple hopped, for example, if you've gone CPT to service type code to backend system, or vice versa, service type code to procedure code to backend system, you can get into a sticky situation where there could be a lot of essentially misquotes on your 271 if you haven't really done the due diligence to look at how your claims are processing and reverse map how your 270s should process then after the fact. One thing with the 270 is that it's not always pre-service. A lot of times people use the 270, 271 at the time they call and make an appointment. And then when you get to the doctor's office, they verify you still have coverage a couple weeks later, or however long between your appointment and you made and the time you showed up. Then when they're potentially referring you to another provider, they may do an eligibility transaction to check to make sure that you're eligible to be referred and whether or not a prior authorization is required or not. And then you go to that next step where they might be doing a claim and they're doing some pre-validation prior to the submission of the claim. So it really depends on where you're at in that workflow, whether or not that 270 can be generic, more like, is this person covered? What's their copay deductible? Do they have an HMO, PPO,
Right.
et cetera? All the way
Right.
down to, I'm going to give them a medication, I'm going to give them a lab test, and I'm also going to send them for an x-ray. And these three things, some of them might require prior auth, some of them might be covered, and some of them might have to come out of pocket. And at the end of the day, the provider has to answer or ask those questions in a way that the 270 is most generally supported, and that's with service type codes. So what's the appetite for moving to procedure codes? I think the appetite is there. I think the problem is the system changes that would have to happen to get us there, because it's a complicated conversation when you're talking about claims, which is why it's good when we're starting with pretty big categories, surgery, imaging, PT, OT, through the operating rules, that if and when those become mandated, everyone's going to be doing the same support. Everyone's going to be required technically then. So we won't have questions about companion guides. Do you support this? Do you support that? And it will really be about your book of business and what that policy says, as opposed to if you support procedure codes at all.
Right, right. So taking baby steps within the industry by kind of peeling back the onion, using all kinds of analogies here, like physical therapy, occupational therapy, imaging, surgery, can get the industry making those kind of steps together so that the mappings, the crosswalks can take place so that it makes it easier for everybody. Another question that was submitted online here is questions about the dental STC codes and having them added to the 5010-271 support, I guess. I know that the current list of STC codes that are part of 5010 do include some dental therapy specific benefits. Any Everett or Donna, concerns or issues about other dental STC codes that might be in the extra list versus not yet available in 5010?
Well, that's a good plug for the future service type code list, since you mentioned it. The future service type code list, we've made it external. So another little note to self, we've made it external so it could be managed almost just like a procedure code could be, where X12 themselves won't be the owners of it. Essentially, it will fall to a code maintenance group that will be the owners of it. And that can really help us keep up with the way business changes and the healthcare landscape changes. And then because the 270, 271 is used within property and casualty and workers' comp, it can also be easily transformed to use in those domains as well. So it's a good plug. The external service type code code list that's out on x12.org. You can look at it now and see what's available out there and get years ahead of the game to start looking at what you think you're going to need from a service type code to get it out there now so it's ready. And then it's going to be managed on a very similar cycle as some of the other external codes that are maintained within the ASC, RSC wheelhouse. So it will be a few times a year that things can get updated, where we're not bootstrapped with an actual version change to go from, say, 5010 to 8050. We won't have to wait the 2, 3, 4 years in between guides, because those available codes will be, once they're added and then the effective date is hit, they're open for use. That does mean, though, that if there's new codes added, clearly companion guides are going to have to be reviewed more frequently, and make sure that we're keeping up to date our companion guides to let providers know and vendors and clearinghouses know what each of the payers are supporting, to make sure that we aren't, I wouldn't say false advertising, but we're limiting. If we limit the exposure, then we're really not doing ourselves any justice. That those service type codes are there for people to use when we move to that next version, and it has to be useful. So it's not going to be useful if people know the codes are out there, but nobody's advertising that they're accepting them.
Yeah, so a couple of things maybe from that to distill, that there is an entire set of STC codes that are outside of the current standard version 5010. And that new set is much more granular, provides a lot of different codes that don't exist today in the standard, but they're available for folks to start thinking about, because that future version of the X12 transaction would adopt the entire set. So it allows for much more greater granularity and detail for those specialty benefits, for those specialty providers. Again, all of this goes back to perhaps understanding the benefits better, understanding the financial impact for your patient, your member, and for your provider. It allows for you to understand that level of specificity much more closely and carefully. So again, not all of the dental ones are in the current 5010 guide today. There are some. There's many more of those in the future versions, or available for future versions of the TR3s with the future version of the X12 transaction.
Right.
I'm going to jump. Oh, go ahead.
I was going to say there's also, again, another insight into potentially the future that you'll see. There's a couple new sections in the front matter that helped bridge that gap that existed with the dental community. So there is a whole section that the folks who represented our dental associations did help us with. So we built some functionality and capability and kind of helped guide people for the front matter. And then we've added new segments to help also in the dental world. So it isn't just listed as code set or code values. We've gone a little bit further to help the dental community start using the 270, 271 a little bit more regularly and not feel like they were left off or treated like a stepchild.
Great. I'll move over to our next topic, which is related to copay maximums and accumulators. Know that this is another topic that's important for providers to understanding what is the copay maximums that are available for a member or for a patient, and the accumulators, especially for those types of providers that like chiropractic, like a physical therapy, where you have so many visits available for that member. And you want to make sure that you can schedule those out according to what is required for their therapy, but ensuring that they don't bump up against those maximums. How does the standard support these types of patient financials and accumulators and this type of data?
The standard and the implementation guide both support the remaining, and it's usually from the perspective of the remaining as opposed to used. I guess technically they both are. You could be intuitive and say it might say that you had a quantity of 10 allowed and you've used 5, which means you have a remaining 5. But there is a way using some of the code values in the 271 on the EB segment, and then even within the loop, there's something called the healthcare service delivery segment that also can be used. It's quite confusing on how to use the HSD within the 270, 271. We've kind of cleaned that up in future versions, but the best, this is going to be a plug for another one of our work groups on X12, but the people who are most confused with how our HSD segment instructs folks to use it, we advise people go look at the 278 transaction, the X217, I believe it is. They also have an HSD segment, and we liked how they defined and described in their segment situational rule and their tier 3 notes how to apply and use the HSD segment. So if there's ever any question on how to use it within the eligibility transaction, take a peek at that 278 HSD and use it the same way, because that will, one, keep us in sync, because we really should be, as much as possible, especially sort of related transactions, be in sync as much as possible. But then because theirs just made more just sense, just reading it, and it made more sense than how we tried back in 1998, I think it was, and then 2002 to write that part of the HSD. I think we just didn't do a great job at that point in time. We were pretty immature in the use of the HSD. A lot of the developments of benefits and their delivery patterns weren't really defined as well as they are now. So the best thing to do is look at the 278 and see how they would explain how to use the HSD, and then apply that same thing to the 271. And that can get you a lot more information about your copay maximum, your visit maximums. Like, are you allowed 0 to 1 visit for $10 or 2 to 10 visits for $15? It will help you understand how to apply the usability of the EB and the HSD in tandem to help each of those segments out.
And again, the guides, the implementation guides, the TR3 implementation guides from X12 do a great job of explaining the use, the methodology. Sometimes implementations are more challenging, but you can work with your vendors and your clearinghouses and with your health plans to make sure that you're getting the data that you need when you need it, because it is supported by the guide. So you want to make sure that you do get the data as a provider or as a vendor, that it's coming through, that there's no oh, we didn't map it because it's an optional field or it's situational. We are in this particular segment and it's never a situation that's going to pop up for us. I would caution against those, because the industry changes quite a bit very rapidly. So expanding the use of all of the fields in the implementation guide, I use the analogy, the levers, turn on all the levers. So if the data is flowing from the health plan, it makes it all the way to the provider who might need it. So don't make assumptions about the data flow unless you have those really well vetted out. Another topic that we have on the next slide was multiple 271 responses. Again, I know this has come up in the industry as well, where perhaps the provider sends a single 270, but because of the way that the data is structured, perhaps they've sent in multiple STC codes on their original 270. It branches out perhaps at the vendor or the clearinghouse or even at the health plan. And is it possible to receive multiple 271 responses back from that single inquiry? Is that also supported by the IG? I can give this to Don or Everett. Comments, questions?
It is possible. There may be different systems that the 270 passes through as it goes through the payer system. It may hit an initial system that looks at it and sends just an initial response, and then it may hit a system that provides eligibility or benefits, or it may go to a different payer at some point in the process, depending on how the benefits are structured or set up. And that being the case, you know, there may also be something that takes a little longer to return. So you may have a real-time response initially, but then you may have a batch response at a later point in time. I've seen that as well. I'm so and that doesn't it's not that a later response would invalidate, just to be perfectly clear, it's not a later response would invalidate an earlier response so much as provide further detail or clarification on the benefit being provided.
Great, thank you. Yeah, so also make sure that the key point that the functionality exists. You want to make sure that your practice management software, your vendors are supporting that functionality,
Right.
so that the data comes through. So that one to many is something unique, and it's also important for providers to get all the data that they need.
Again, I'm providing more of a clearinghouse
Yep.
perspective, and so Donna would probably might give more of a payer perspective on this.
Yeah, and I would say from a payer perspective, we traditionally don't split out the 270 and break it apart and then turn it into multiple 271s, mostly because we figured that would possibly be a challenge for the recipient of the 271s to marry more than one transaction, more than one trace number, different control numbers, et cetera, back to that original 270. We would definitely rely on a clearinghouse or a vendor in between if there was a need for us to support that, to kind of do that combine and marry. The other flip side of that is if we really didn't support, in our case, if we didn't really support a particular type of benefit because it's out of our wheelhouse, it isn't part of our domain. So example would be maybe property and casualty. If by chance somebody sent us a medical inquiry for something and they also wanted to know something about a property and casualty situation, which I'm going way out on a limb making this up, I don't think that we would, from my personal payer perspective, we wouldn't respond to the property and casualty piece because we're not a property and casualty insurer. So if something came to us inadvertently, we would traditionally respond with what we have in-house. And then if it's something that came in and they asked a specific question about something that had to do with a property and casualty policy, there's no way we would be able to answer because we don't do that business. On the other hand, if someone came in and gave us procedure codes or something to those effect, and we can't support procedure codes, we would do what the guide says to do, which is turn it into the treating it like it's a 30 that came in and answer the 30 with the response that we would supply back if a 30 actually came in instead of a CPT code. So there's a lot of different ways that you can answer the question and split the 270 and 271. From a payer perspective, I could say we don't do that, so I don't really have a lot of experience with it. I would defer, as Everett did, to how a clearinghouse or a vendor would do it. And then also, caution that it would only probably be smart to do it if there was truly a need to split, meaning maybe you had to forward part of the inquiry to a carve-out vendor, like a vision vendor, because someone asked for vision and you don't support the vision benefits, or maybe even the dental vendor or the dental insurer. Maybe you're just a conduit to them and you just have to forward it. I would still recommend that originating receiver, so that health plan that has to do all the slicing and dicing, that maybe they would consolidate the response and then send one 271 out just to make sure that there's one 270 and one 271 to marry.
Great, thank you. I know another topic on the next slide is that the COB payer name. This is important for members that might have multiple coverages and multiple policies. Is it possible to support returning the secondary payer information within the transaction?
Absolutely. You can use the 2120 loop that helps define whether or not it's a primary, secondary, tertiary payer. And for that matter, it doesn't always have to be the secondary payer, because the 270 could have gone to the secondary payer, and the secondary payer could say, hey, there's another payer who might be primary, could be tertiary. So there's a way to say that there's other payers and plans. That's a requirement in the front matter of the existing 5010 in, I believe, 1472, which is the section. It should be in that section, or the 1472 or 1471, which explains that we are required as payers to return other payers and plans if known, and you wouldn't return the benefits for that other payer. You wouldn't return their potentially whether or not that member is active with the other payer or not. You would simply return that, at least in your system, you recognize that they have another payer. It would be then up to the provider or whoever's conducting the 270 to route a separate transaction to that other payer, potentially after they validated that there is another payer with the patient.
So another good thing to note that the data is available to be sent to the provider when there is a question of primary or secondary and who that payer is for that member. Again, if it's on file with the health plan that you submitted your original 270 inquiry to, you should be able to send that information if it's available. So it's important, again, for providers and for patients to understand that the data is there, right? Making sure that comes back in the response. I know we're getting close on time. We'll jump to the next topic real quick, date of service. I know that for dates of service, the operating rules require these types of inquiries to support dates of service back 1 year and up to the end of the current month. What about future dates or even dates that are older than that? How do health plans respond to dates of service that range quite a bit? Or vendors for that matter, Everett?
It varies considerably from one payer to another on how they, some will just totally reject future dates of service. Some will accept future dates of service like within a year or something like that. But they'll usually have very specific parameters around what dates of service are allowed to be sent. That's my experience.
So again, lots of variability.
Yeah, and
lots of
I would say
variability.
the same thing. We typically don't support eligibility and benefits past the year or up to the end of the current month is where we limit it. We don't go beyond the end of the current month, mostly because so much could change when it comes to the future quoting. And then the problem with the past is really, it's just, we log these transactions and keep them around. So we want to make sure that we keep it within that window that, one, we're required to support from an operating rules standpoint, but two, what makes the most sense from a storage and capacity standpoint. Again, a little nugget in the future versions of the Tier 3, we've made that a tweak to that requirement. If, all things being equal, if that Tier 3 goes forward and is mandated for adoption, then we actually have in there that that people have to, information sources have to support either a year in the past, I think it's a year in the past, or up to their timely filing requirements. So if you have timely filing requirements of 3 years for claims, then naturally you're going to want to support a 3-year look back for eligibility, because if a person can file a claim, they might need to validate some information prior to submitting that claim. So we are trying to keep the claim transaction and the 270 transaction in sync, again, for supportability. So that may change again as long as the future version becomes effective. That would be a new add and a value add that we've been asked to support in the implementation guide in the future. It doesn't stop you from doing it today. There's just a lot of people choose to stick to the minimum requirement, which is typically the operating rules, which say a year in the past.
Yep, great. I know we're coming up on the hour, so I know we had a couple of questions about how you can become a member of X12. Go out to x12.org's website. We also have a couple closing slides here for becoming a core participating organization as well. If you're interested in working on the operating rules, you could come join us as well as X12. Again, X12 develops the standard, core develops the operating rules used in tandem to bring the benefits to the industry. We also have a certification program for like Everett's organization, Optum is core certified, Availity is core certified. They certify that they can meet the operating rules and the standards. Again, the data exchange mechanisms for connectivity, security, authentication, as well as the data that's flowing back and forth. Again, always being an advocate for what is best for the industry is always important. It doesn't matter which organization that you are in or with. We definitely support anyone who wants to do the right thing for their patients and for their members. With that, we'll go ahead and close and have a good afternoon.
Thank you.
Yeah, thanks everyone for joining us.
Thank you.
And we hope to see you at upcoming webinars and conferences. And with that, we'll conclude today's webinar and hope you have a great afternoon.
Thank you.